Yeah, so we were saying about the what causes the disease and what we know. So what we've learned, and it's a very big story, but it is an interesting story, and you can say that it is just by accident, by luck, it happened that we know what we know. But luck and at the same time very good observation and experimentation that led to the discovery of some drugs that work very well in depression. And these drugs seem to affect primarily a couple of neurotransmitter systems in the brain. Serotonin is one of them, and norepinephrine or noradrenaline is another one. So that led to the hypothesis that since these drugs work by increasing serotonin and norepinephrine in the brain, the theory was that, well, that means that then serotonin and norepinephrine in depression are reduced. And that has been the hypothesis for many, many years. As we learn more and more, it seems that this is not as simple. It's not as simple that you have less of that, and then if you give a drug that gives a little bit more of that, that's it, and it's easy and done. So the reality is a little bit more complicated. It seems that there are different symptoms, that there are different categories of people who have predominantly certain symptoms compared to other patients that have other type of symptoms and so on. So unfortunately, it's not one disease for all the people, but each person seems to have their own type of depression, and that makes it very, very difficult to treat depression. It is. So in a way, it is important that people who suffer from depression, that it is important that they do not feel that they are alone, that they do not have, that they have people like them out there, that they have similar problems, and there shouldn't be any stigma. You understand the word stigma, right? Yeah. Okay. That it's not their fault. It's not something that they have done wrong, or that it is because they're weak, or or a sin, or something, or because their parents somehow were poor, for instance, or rich, or whatever. That's important to know and feel that they belong to a community and they are people like us. I mean, that depression can affect any one of us. We can be depressed, and our family members of our family. But at the same time, so that's important to know that we're not alone. But the reality is that as we are individuals, most likely our disease is also very personal, and that's why it is very difficult to treat it with one drug, let's say like a magic bullet that can treat everybody equally well. This is not going to happen. Instead, we will have to find ways to treat people and listen to the individual people with their problems and treat them according to what they experience.
So it's kind of like the personalized plague.
It is like, yes, this is a good, yeah, that's a good expression. And in fact, that's the latest initiative. And in fact, even President Obama has talked about that the next target, let's say, in dealing with not only psychiatric disorders, CNS disorders, but in general, the next frontier is to see the patients as individuals and apply exactly what you said, personalized cure to personalized disorder. So, and there are ways to do it, right? The way you are unique and the way your fingerprints, for instance, are very unique and personal. They are only yours. You only have, your fingerprints. In the same way, there are molecular biological fingerprints, so to speak, that can help the physician to determine what is right for you. And this has already started happening for some diseases like cancer, for instance, for brain cancer, for breast cancer. I'm sorry, it has already started being going this way. With psychiatry, we're not exactly there yet. It will take a little bit more time, but eventually we will come to that point where, just looking at your DNA, we may be able to help determine which drug treatment or which other treatment, other type of treatments, biological treatments, will be good for you.
I like that personalized plague.
That's very good. It is like that. Yeah, very good.
So my next question is how does SAD or God, I forget what the how does SAD differ from major depression, major depressive disorder, or MDD? Are the neurotransmitters involved? Are they the same ones? Are the treatments the same? Like.
So you mean a seasonal affective disorder?
Yeah.
Okay. Yeah. Well, seasonal affective disorder is, I would say, one subset or one type of depression or depressive disorders, and that goes back to what we were saying, right? That there are different types. So it seems that some individuals are a little bit more susceptible to changes in weather, in light, in seasons, and especially winter is and lack of light is associated with depressive symptoms or symptoms of depression. Indeed, there may be some common elements, but there may be also some other neurotransmitters that may be involved. There is an internal clock, let's say, in our body that regulates when we sleep and when we wake up, and also it regulates changes that happen over winter or over summer, over the different seasons. So it may be that there is a dysregulation, as we say, or lack of regulation in this system that is responsible for seasonal affective disorder. Treatments can be the same. There is also an overlap in treatment. Some people use antidepressants, but there is light therapy also has been shown to be very effective. And we talked about that when we talked about a little bit other biological therapies. I mean, light therapy is a biological therapy. In fact, I would argue even what we used to call psychotherapy or behavioral therapy, that is, talk therapy, is actually also biological therapy, because ultimately by talking and by intervening and by discussing things that have happened to you and your history, you affect the way you react to things that have happened to you in the past, and that changes how you react to things that happen to you now and in the future. So in other words, the brain is not is very plastic. It has a lot of plasticity, and even the worst things that have happened and affect people's behavior in some ways can be not necessarily undone, but affected in that way, so that there is some kind of relief to suffering and pain. So in fact, other than drugs, psychotherapy, behavioral therapy, cognitive behavioral therapy, depending on the indication, depending on what type of depression or other anxiety disorders, for instance, can have a major impact. But don't fool yourself. All these interventions are biologically based. I mean, nothing happens outside of us and our ability or the ability of our brain to adapt.
I'd not thought of it that way, but it makes perfect sense. I mean, the plasticity.
And there are two theories in emotion: the James Lang theory on emotion, and the Cannon-Bard theory. Which one do you think is more helpful scientifically? Is one is the scientific community recognized as correct?
All theories are they have some bases that make a lot of sense, and I think it would be wrong at this point to dismiss any theory. Even what we were talking before about psychotherapy and which is based in psychoanalysis, which for years was considered that it was a major way of looking at mental health issues, and then it was not anymore, let's say, current, and people did not believe. Now, recent data, recent research has actually shown that some of the ideas that have been developed in the past 100 and 150 years ago by some very bright people, although they didn't have the evidence and all the information, like Sigmund Freud, for instance, he was right in many aspects. So I think that all these theories have some elements that are worth examining. The basis, again, has to be always biological, and I think no theory should be dismissed without really having the biological basis of any theory examined.
In your experience, do cultural influences greatly affect the response to a stimuli? Is it like specific to certain areas in the world? Do they react differently? Like, for example, would a Japanese person respond to a bad grade like an American would, or would they respond differently?
Hmm. Yeah, that's a good question. Uh, yes, it is a very good question, and the truth is that um, there are there are some stimuli, as you call them, that are universal, that are global. Right? When you are threatened by something, when you fear, the fear of darkness, let's say, or the fear of big animals, let's say, these are universal, very. These are feelings that go back, thousands and thousands of years, and they apply to all of us. Okay, but from there on, there have been different societies, and societies have different norms. In other words, what we consider normal and physiological is not necessarily normal and physiological for another society. And even in the societies that are today across the globe, even in advanced societies, because the Japanese society is very advanced as the American society or the Western societies. But there are some subtle differences in what in the impact that different stimuli have. So, for instance, I'll give you an example: the threshold for pain, how people experience pain. Actually, there is a difference between men and women. So women clearly have a higher threshold for pain than men. Sorry to say, but it is true. I mean,
That's what I did my postdoctoral work on.
Right. So men do not, in spite of whatever you hear, men do not stand pain that well, do not tolerate pain.
Just ask a dental hygienist.
So, also all this toughness is for nothing. Actually, the real tough gender is not the masculine one, is not the male one. In any case, so there are differences, right? And there are also differences in pain threshold between different cultures. So the Japanese, you can measure the slight differences in pain threshold between Asians and Caucasians, for instance. So all in all, you're right. That's a major impact. Which, by the way, it is interesting that you bring that, and it goes back to what we were saying, because it comes back to this issue, nature or nurture. I mean, what is most important? Is it what you have in your genes, in your DNA, or is it, how you are? How you grow up, what is the environment, what are the impact and the influences that you had growing up from your parents and so on. Well, the reality is that there is both, right? There is influences that are genetic, and there are influences that are what we call epigenetic, influences from the environment. And now we recently, actually the last 10, 20 years, we have started to understand how important this epigenetic, the influences of the environment, affect the DNA actually. So, which before was unheard of. We thought that, what you have in your genes, that's it, and it doesn't change. Well, in reality, it does change a lot, and so environment plays a major a major role in everything, in our behavior and in behavioral issues, if you want. And of course, genetics, and there are many genetic disorders, for instance, also play a role. So in reality, it is a combination of nature and nurture that determines who we are, how we face the world, what becomes of us.
And this is my last couple of questions.
Good.
There's literature that suggests that certain colors, this is actually what I'm writing an essay on,
Okay.
that different colors affect different emotions in the working environment and other environments. Are you aware of this research, and do you know, is it the color themselves, or is it like the wavelength of the color?
Yeah. This is interesting because, and it's interesting that you mentioned that in relation to your previous question about seasonal affective disorder, because when I was in Sweden, I worked and lived in Sweden for almost 10 years. Well, first of all, seasonal affective disorder because of how north Sweden is, and especially where I was at, they had a lot of issues with SAD. And color in hospitals, for instance, and in houses was a major topic of discussion. And they had developed a whole science around colors that when you enter a hospital, for instance, should should be exposed to, so that it helps you calm down. And they had done experiments where they had measured, physiological parameters, blood pressure and heart rate and temperature and things like that, and sweating, and they had found that, for instance, light green color is much better than aggressive orange, red, and it calmed you down if it was green. So they had, and I don't know if it was the wavelength
or the color association.
I don't know what it was. Maybe it was association, as you say, but it really made and then they had, because it's a small country, but at the same time they are very they can afford to be very careful in taking care of these issues. They spend a lot of research in what they call social engineering kind of approaches. What kind of colors we use in schools, in public offices, and so on. So nothing was left. Oh, okay, let's put a bright red here. Nah, I mean, maybe that was not we shouldn't have that, or healing colors and things like that in the neonatal unit.
Neonatal
Babies. So it was interesting that, and so there is a lot of research around that, and I don't know the latest, but I believe that there is some truth in that. The same with the light. If you think about, especially nowadays with these blue screens and our mobile phones and things like that. I mean, we are always even late at night, and I think we don't use TV that much, but we have these little screens now, and it's probably not very good, I think.
Yeah, there's more and more data you see about turning that off long before it's bedtime.
Yeah, exactly.
Which we all do.
Yeah, well, yes. But they say now that I think, I don't know, it's almost like 90% they live, in arm's distance from their iPhone or iPad, or 90% of humanity. I mean, it's, if you think about it, it's crazy. And there are some villages in Africa, for instance, that they may not have refrigerators in a way, but or washer and dryer, but they do have an iPhone or even a tablet,
Right.
which is
Yeah, it's amazing.
amazing.
Oh, that was all my questions. Thank you very much.
Good. Did you get